by now you realize the redundancy, and so I will skip over some things that have already been repeatedly mentioned and dwell on the things that maybe there's some differentiated perspective I have here. So in 2019, they asked me to do more or less the same talk, and so I have more perspective and experience now in some of these things, and also the opportunity for follow-up that I can share with you. But I have to go back to really 1988 and then in 1993 when I was traveling fellow, doing these surgeries with Gerber. And in 1988, we would go to the cadaver lab and do them in the patient. Then in 2024, Bassem came on the scene. Actually, 2017 is this picture of the tendon transfer course at the Mayo. And some of you may be aware there is a sold-out now tendon transfer course at Harvard for all of these different types of transfers. Now, what your philosophy is or opinion is depends on where you work and who your mentor was and who teaches you. And so, with the ancient Chinese proverb, many a false step was made by standing still. So we are not standing still. We have ADD of innovation. And tendon transfers is some example of this. And it's disturbing to see that we maybe don't differentiate as much as we think we do when we actually measure what we're doing. I have some conflicts, but I'm not going to talk about any specific things here. Now, Gerber sent me this photograph of his perspective on Switzerland versus United States. And I can tell you Switzerland has been much more impactful for me. So it's a little more like this where I'm concerned from the standpoint of what I started with as my foundation and then what I continued with. And in that way, I'm somewhat different. And, I know there's been some controversy with Dr. Gerber, but one thing that he is innovative. And way back when we were partnering together, I was comfortable to understand that I was the king of the hearts, and he was the ace that was made by Sulzer, a company no longer existing. But now I have Bassem, and Bassem is running with the ball for tendon transfer. And if I'm talking here, much of what I'm going to tell you is what Bassem has taught me now since he was my student. And so if we look at all these different things and we look at the literature, there are many people that deserve to be acknowledged, and Miyahata is one of them. When you talk about SCR, I think he was a speaker here previously. And so Florian, of course, spent some time and reviewed all this when he was with us, and this is one publication going through all what we're talking about now, although some time ago. And, if you look at the literature, it's confusing what we're talking about. You've already seen this from the other speakers. And we all understand about the different criteria, but are we treating pain? Are we treating muscle quality or fatty atrophy or functional loss? And others have said this, and what is the Hamada classification? And of course, we have this frame of reference to look at, but these are not precise. They are percentages for when you can do one thing or another, and then you can try to create categories in which you would do one or the other, but there are always exceptions. And it's the exceptions that make it clear that we are not perfect in our decision making. Well, if you look at what the literature reflects, it's fascinating to see, and it's in context to the current climate in the world in which I live, which is flavorful to say the least. And so if you look at latissimus transfer, modest growth in Google Scholar for interest in this. If you look at lower trapezius tendon transfer, this is an enormous growth, but largely because of the personality and influence of Bassem and some others in Europe that have worked with him. And if you look at SCR, modest growth, and I will talk about that a little bit more. And then superior capsular reconstruction, again in Google, which is we're going to have more science fiction too. But I would like to quote this wonderful book written by Ozan Varal, Think Like a Rocket Scientist. And when you look at all these people, his quote is, "Our tendency towards skewed judgment partially results from the confirmation bias. We undervalue evidence that contradicts our beliefs, and we overvalue evidence that confirms them." And this is exactly the way surgeons function. And to step back from this and to give people credibility for what they identify that may be different than you is really important. And so when you look at PubMed, which is at least some measure of scientific validity, you can see the enormous growth over time in all of these categories of treatment, although you will notice a trailing off of SCR, and I'll talk about that in a moment. I won't talk about the principles. Others are more qualified, like JD or George, to talk about this, but this is very important in understanding the basis for why we do what we do. And this is drawing from Bassem, we've seen over and over again. This very important graph here talks about the rationale for why one tendon transfer may be better than another from the standpoint of potential excursion, that it is the case that the lower trap transfer is somewhat better than latissimus dorsi mechanically, and the same goes for relative tension. So that makes some sense. But then why would latissimus dorsi actually work? And I'll go over that in a minute. So this is a very active transfer. This is from Bassam. You can see the muscle contracts, and clearly it's in phase. And you can measure this with EMG, and they're doing a lot of research now to demonstrate to what degree are the tendon transfers actually active in vivo. And that's the basis for their conclusion. They are reaffirming what they believe to be the case. And so when you look at all these things, all the authors are reaffirming what they believe to be true, which is interesting, that we have a sort of a requirement that we have to affirm that what we believe is really so. SCR, you already know about the marketing and mechanics, perhaps, of some of the biomechanics that's been done there. This is really a premier article published by Pat Dennard. 68% success. It was Burkhardt that was very, very upset about this and took his own patients out and published much better results. So, that's a problem. And all these different variable outcomes that are small level 4 cohort studies, great clinical outcomes. There's another one in 86, reversal of pseudoparalysis, what Burkhardt says, which for me doesn't make mechanical sense, but reaffirming. And then another one, 3 to 36% re-tear rate, another one greater than 14% re-tear rate. Re-tears were correlated with clinical outcome. And in our work, which really created a very big, what's the word I'm looking for, conflict with me and Dr. Burkhardt, because I questioned things, and all I did was look at our results. This may reflect how bad we are as surgeons in doing an operation that he's so good at. And in fact, when we looked at our cases, we had zero effect on clinical outcome with SCR. Now, to be fair, this may be learning curve of many of us. And in fact, what's interesting is when you look at the learning curve over the short term, if you look here, the initial experience was very, very poor in terms of reoperation rate. And even the best surgeons after 20 achieved not really very successful outcome. And so, 77% failure rate in the first 10 cases and 80% failure rate if they had prior surgery, et cetera, really calls into question some of the conformational bias that exists for those that really put this forward. And here's an editorial entitled, "Even with high re-tear rates, shoulder capsular reconstruction outcomes, SCR, we're seeing an increase, but we're seeing an increase in strength." So this had high rates of complication, including re-tear, loss of fixation, and incomplete healing, but use it anyway. And another one here, midterm outcome, re-tear rate of 62%. And yet another one here, and I can bludgeon you with all this data. This one, a very interesting one, the number of surgeons using SCR and rotator cuff repair is declining. Surgeons performing greater than 100 rotator cuff repairs annually, only 42% are doing SCR, okay? So it's simply just been not durable, and it follows what we call Scott's parabola, which is enthusiasm for growth, and then loss of enthusiasm with evidence. And so if you would look at these things, I started with latissimus dorsi because I trained here in the late 80s, and it was really Gerber who helped me understand this, and then Boileau mainly with reverse replacement, as you saw already. The irony is that Gerber thought of this idea based on what he learned in pediatric orthopedics for the Lepiscopo procedure, and then I wrote of my experience, and I won the Neer Award for something he created, which is kind of odd if you imagine that. And so what's interesting is subsequent studies demonstrated that how can this work if 35% don't retrain successfully on EMG, the latissimus dorsi, which is out of phase. And in fact, if you do this, and I'm convinced of this, you must do biofeedback training to make sure the muscle converts. And not everybody has the plasticity mentally to convert from something that is doing this to something that is doing that. And that is not necessary with a lower trapezius transfer. And I've done this operation all over the world and have gone back in certain circumstances with biofeedback training to do the training for the patient. We learned to do this arthroscopically, which scaled it. These are all the different studies that demonstrate, and even pain relief is affected. Not sure why, but it is affected in our patients. So these are the differences mechanically I already talked about. I don't want to dwell on. The technique I won't talk about. Others have talked about. When we looked at comparison, which we did, because I had Eric Wagner that was Bassam's fellow. We looked at these. We looked at SCR. We looked at tendon transfer, both lower trap and latissimus dorsi, and tendon transfer was better for VAS in our evaluation. If we looked at this now with ASES score, no difference, but probably smaller cohort. We looked at it again for subjective shoulder value. Tendon transfer was better than SCR. We looked at it as well for pain relief, arthroscopic versus open. Arthroscopic was better for pain relief than was open. In my cases alone, same thing when I looked at my own cases, significantly better. And we looked at recovery processes for SCR versus tendon transfers. Actually, oddly enough, similar pain recovery and functional outcomes, which was disturbing, but also Joaquin found this. But I leave you with this one case. Look at this patient here. 48, 9 failed prior surgeries, supposedly tendon transfers by hand surgeon, nerve release, no functioning suprascapular nerve after nerve destruction, I would say, not release. Profound lag sign here. This was before I knew of doing lower trap transfer. And, clearly pseudoparalytic with the dropping arm sign or whatever you want to call that, deflection lag, etc. And, you can sort of see here, I won't belabor this, but look at this lag sign in abduction, which is critically important to function. And so, with him, I didn't know what I was going to find. So I did an open approach anteriorly and posteriorly, and I found that latissimus dorsi was still there, but was scarred to the lower trap. And I, of course, didn't know scarred to the teres major. I didn't know of lower trap. And so then I did this from front to back and transferred each of these. First, I transferred latissimus dorsi, and then I wanted more strength for the patient. I also transferred the teres major, and then fixed it through this approach I learned from Gerber of acromion osteotomy, as you can see here. And this should be out of phase, right? So here's our patient.
All the way up.
90% subjective value. This man was a workers' comp injury and returned to work. So I can tell you, I am 100% certain that both lower trap and latissimus dorsi work as well if you do the right rehab and the right patients as you pick them. And that if we continue to try to prove that one is better than another, that is fruitless and a waste of time. And so it's a little like trying to change a golfer's success in making par, the way he plays the game. It doesn't matter what it looks like. The scorecard is the same no matter what you're doing. So I just want to leave you with that because I can't do better than that with a lower trap transfer. Certainly, I don't do that well with an SCR. Thank you.